case of atrial thrombosis in a COVID-19 patient with multiple hypercoagulable risk factors. To introduce this topic, I will briefly discuss Virchow's triad, which describes three factors that predispose a person to thrombus formation. First, abnormalities in vessel wall. Second, stasis of blood flow. And third, coagulability of blood. These factors encompass a wide range of conditions, including inflammation, atherosclerosis, and malignancy. Atrial thrombus formation and left atrial dilation is most commonly encountered in rheumatic mitral insufficiency or atrial fibrillation. Valvular damage causes decreased blood flow. Likewise, AFib causes increased stasis and turbulence within the atrial cavity. In response to the increased intracavitary pressure, the left atrium dilates to reduce pulmonary hypertension and edema. This causes increased stasis of blood flow in the left atrium, thereby increasing the risk of thrombus formation. COVID-19 began in December 2019 in Wuhan, China, and has since caused pandemic. In addition to the acute lung injury, coagulopathy has also been identified in patients who may present with elevation of D-dimer and fibrin degradation products. The incidence of thrombotic disease in individuals affected by COVID-19 is reported as high as 31%. The virus does not appear to have intrinsic procoagulant effects itself. The abnormalities in coagulation tests are most likely a result of profound inflammatory response. So for our case, we have a 75-year-old female with a past medical history of stage 4 colorectal cancer with metastatic disease to the liver, on chemotherapy, atrial fibrillation on Coumadin, and coronary artery disease, who presented to Huntington Hospital with a recent COVID-positive screen. The patient had an intermittent dry cough without productivity for the past week. She reported to the emergency department after spiking a fever of 101 Fahrenheit. She also had a decreased oral intake, lightheadedness, fatigue, and loss of taste and smell over the past week. On admission, she was tachycardic in atrial fibrillation with RVR at a rate of 135. Digoxin improved her heart rate to 80s to 90s. She was asymptomatic, however. CT demonstrated an impressively large left atrial thrombus measuring approximately 4 by 4 by 7 centimeters. Image 3 demonstrated layering along the back of the left atrium, characteristic for thrombus formation. There was no stalk or attachment to the septum, which would be more indicative of a mass or myxoma. The patient's INR at admission was 4 and remained supra-therapeutic throughout her entire hospital stay while off Coumadin. Image 1 here demonstrates turbulent blood flow through the left atrium and through the mitral valve. Echocardiogram demonstrated left ventricular systolic function mildly reduced between 45 to 50% with no regional wall abnormalities. Image 2 demonstrated this patient's enlarged atrium, measuring 5.5 centimeters. In terms of her COVID pneumonia, the patient was started on antibiotics as well as a combination of vitamins for immune support. In terms of her cancer, she was pancytopenic throughout her stay, and CT demonstrated rectal wall thickening and a perirectal nodule with mild progression of liver metastases. The patient refused aggressive or further treatment. Palliative service discussed home hospice for the patient, and she was discharged home. In terms of her atrial thrombus, she was discharged on a prophylactic dose of lovenox. Warfarin was discontinued with no plan for an INR check. To discuss this case, while intraatrial stasis plays a major role in atrial thrombosis, it does not fully explain this patient's case. Here we have atrial thrombosis occurring in the setting of multiple hypercoagulable factors, including COVID-19. The patient had multiple chronic risk factors, but this was the first time she developed a thrombus with no changes to her anticoagulation regimen. This case also highlights therapeutic failure on warfarin, a condition where warfarin did not provide a clinically successful thrombosis prevention. This has been described in antiphospholipid patients where lupus anticoagulant can artificially raise the INR but does not reflect the true level of anticoagulation. Furthermore, in a small randomized controlled trial, high-intensity warfarin was not shown to be superior to standard treatment for preventing recurrent thrombosis. Because of this, we discharged the patient home with lovenox. This case provides further evidence of COVID's coagulopathic effects and possible interactions with anticoagulation. It may help direct future research into this novel disease and its atypical characteristics.